Welcome, everyone. Really excited for another excellent tumor section webinar. Today we have Dr. Lorenzo Bello from Italy, who will be discussing important mapping techniques in glioma surgery that he's developed and really helped teach us to perform better surgery. Dr. Maria Noor Huda will provide a more formal introduction. Once again, I want to thank our AANS team members here who've made these webinars available. These are on the Tumor Section website that you could access later. They'll be posted there. And we're so excited to provide this educational content to our Tumor Section members that span the globe. So once again, thank you very much. And Dr. Noor Huda, the floor is yours.
Thank you very much, sir. It is an honor and a pleasure to introduce Professor Lorenzo Bello, who is considered a world leader neurosurgeon for the treatment of intrinsic brain lesions using brain mapping techniques. So a little about him. Professor Bello is a world-renowned neurosurgeon based in Milan, Italy, and is currently the head of the neurosurgical unit at the University of Milan. His pioneering work focuses on functional brain mapping in patients and also integrating neuroimaging with intraoperative electrophysiology. He has authored influential papers on motor cortex plasticity and surgery in neuroiliquent areas of the brain. He directs one of the international references group for the treatment of brain lesions using brain mapping and monitoring techniques and awake surgery, particularly for low-grade gliomas, as we know. So Professor Bello has a lot of contribution in this field of brain mapping, and he has a lot of, many of you who are interested have already read several of his papers and attended his workshops and several educational events. So it is a real honor to welcome him today for our webinar. He will be delivering a talk on advanced motor mapping for glioma resection. Thank you very much, sir, for joining us today and for spending time from your very, very busy schedule on Friday. The floor is all yours now. Thank you very much.
Thank you so much for the nice introduction. I think we can start. And the topic of today is advanced motor mapping for glioma resection. And first of all, why we need brain motor mapping for glioma resection. We have, in fact, to start with evidence-based guidelines from, I show now here, the guidelines from EANO, the European Association of Oncology, in which extent of resection is a prognostic factor, but should be balanced with the maintenance on functional integrity. And for doing this, we all know that the functional approach is the approach of choice. And when you are doing this, you have, in fact, to define the relationship between the tumor and the functional boundaries using neurophysiology and neuropsychology as guidance, and to resect till functional boundaries are reached independently of where they are located to a visible MR border. And if we are doing this, the functional boundaries can be inside of the tumor, so we get a partial subtotal resection. At the tumor border, we have a total, or outside of the tumor, and we have a supratotal resection. Supratotal resection is, in fact, a resection extending beyond what is called traditional MR visible tumor border. We have two settings, one in the mute and one in the wild-type gliomas. We all know the typical pictures, resection of large part of apparently normal brain parenchyma, which has huge impact on PFS in all molecular subgroup and grade, with a low percentage of recurrence at 12 years. Huge impact on overall survival, again, in all the molecular subtypes and grade, and in wild type, as shown by the RANO-RESECT, also a huge impact on PFS and overall survival. Of course, this has to be done and balanced by maintenance of functions, and motor is part of the function that we have to kept. Motor function is quite complex function. Can be simple muscle contraction, multiple muscle contraction, what we call movement, but also the ability to perform a motor skill, to learn a motor skill, to tailor a specific motor skill, what we call action motor cognition. This different level of complexity depends on the functional organization of the corticospinal tract, of the motor system, with the primary motor cortex, that is the main effector, controlling the spinal cord by the corticospinal tract with descending volleys, in which the direct connectivity of the cortical motor neuronal system is the most important one, and controlled by the simultaneous activities of the premotor areas that are form a complex networks all together and contributing at the same time to the motor activity at the level of the spinal cord by a 50% contribution of the corticospinal tract. The principle of motor tracking is to use the stimulation technique at cortical subcortical site to detect a response by either looking to the effector, looking to overt movement or EMG, or looking to connection by CCP. EMG is quite useful. This is the typical pictures of the patient's wide with many electrodes. The advantage, you can monitor simultaneously different body segments, contra and ipsilaterally. You can reduce the current intensity. You can detect impending seizures. These are the typical muscles that are monitored and recorded. I suggest to use a minimum number of 8 muscles. The recommended is between 16 and 24. We prefer to use curved electrodes than the straight one or the surface one because they are very nice and are giving constant stable responses. You want also to use additional electrodes such as those for the cricothyroid or the larynx. The main principle is to combine motor mapping with the stimulation techniques with motor monitoring with monitoring techniques, in which we have basic and advanced techniques. This is the standard neurophysiological protocol that we can use. You have mapping tools with a high frequency and low frequency technique and different types of probes, and the monitoring that you can use with EMG, free running, MEP monitoring, SCCP, ECOG, EEG. I will show you the application of motor tracking of this technology for primary motor cortex lesion and premotor cortices lesions. Start with the N1. The data I'm going to present are around 500 cases done in the 15 years period. The basic step is to apply the stimulation at cortical level to identify the primary motor cortex and to define the cortical excitability and the point of entry. Then we have to work at subcortical level to identify the fibers and by doing this to define the extent of resection. If we want to use the traditional low frequency technique, the pain field one, you see that is characterized by a biphasic type of paradigm, and you have one shot every 20 milliseconds, and generally delivered by a bipolar probe. The motor response can be seen or by looking at patient overt movement or using EMG. When we are using EMG, this is the typical pictures. Progressive motor unit recruitment that increases with the increase in the current intensity. You have a prevalent responses from extensor then to flexor. You immediately see that the stimulation-induced response is different from the voluntary one. And when you go at subcortical level, you switch to tonic motor unit recruitment. This technique has been used several years ago by Penfield to define the functional organization of the primary motor cortex and to design the typical 3 subdivision with a highly somatotopic organization. In fact, by this technique, you can see that in every single spots of the cortex, you can in fact see the activity of different type of muscles, highly segregated, and also induce specific type of movement. The same you can pick up at subcortical level. When you want to use this technique for glioma resection, it's better to have the patient awake. You see the difference in current intensity, and when, in fact, when you are in the sleep condition, you are end up in a high risk of inducing intraoperative seizure because you have to use a high current intensity. The reference paper comes from Michberger group. You see that cortical mapping can be obtained in almost 93% of cases, but at subcortical level, you drop to 73%. So you have 25%, 1 to 4 patients in which you are not able to have any motor response at subcortical level. And this is the reason why many authors using this technique elaborated the concept of negative mapping. Negative mapping is considered safe when there is no response evoked at 6 in awake or 16 milliamp in the sleep condition. This, of course, is due to the features of the paradigm. You have one shot every 20 milliseconds delivered by a bipolar probe, so you need a lot of charge to induce a motor response. And this is the reason why the gross total resection is 50% and the risk of inducing a deficit quite high, because when you find a response, you are already jumping over the fibers. And in fact, these techniques works mainly in lesion like this one, highly defined, and is not working in lesion like this one, in very diffuse inside and infiltrating the corticospinal tract. Also, I remind you the risk of inducing seizure. This is the reason why several years ago we found that we established that high frequency technique, the train of five or the pulse technique, is in fact the best way to induce motor responses and to perform motor mapping. Again, with this technique, you have qualitative data. The somatotopy, as the previous one, is disclosed, but you have also some quantitative data with the standard paradigm, the train of five. You cannot assess the cortical motor threshold, which is the lowest current intensity that give you the lowest EMG response. And this immediately gives you an idea of the primary motor. That depends on patient's features and tumor features, and is quite variable. And generally, these are the current intensity in the sleep setting that you have to use and consider as normal in the different N1 subdivision. When you go up subcortical level, the assessment of the motor threshold gives you immediately an idea of an estimation of the distance between the stimulation site and the one fibers, with the 1 milliamp, 1 millimeter rules. Of course, this is working when the cortical excitability is under normal range, as with the range that I showed you before. You can enhance selectivity by shifting from the monopolar probe to the bipolar probe. When you use this technique in N1 tumors, the standard protocol, the standard train of five technique, is giving a complete resection in 73%, with a permanent deficit very low, is 2%, mainly in tumors well-defined close to the surface, failed in performing a large resection in tumors like this one, deep-seated and infiltrated the primary motor cortex and fibers. For addressing this type of tumors, you have to add to the somatotopy two other neurophysiological parameters, which are excitability and latency. By doing this, you immediately see that in the same site of the corticals of the primary motor cortex, you can elicit motor responses from motor neurons with different latencies and different excitability. So not only, you can also see that the group of motor neurons are giving simple muscle combinations or complex muscle combinations. So what really you induce muscle synergies, recruitment. And the true pictures is not the homunculus as shown by Penfield, but within the subdivision, the right pictures of the primary motor cortex is the mosaic, which represent the functional organization standing for the high diverse motor repertoire of the skilled movement that we are in fact performing. Not only is it also possible to see using this technique, this approach, that the primary motor cortex is organized in two components. An anterior one, which is characterized by lower excitability and giving motor responses of longer latency, and a posterior one that is characterized by higher excitability and given motor responses of higher excitability. This has a cytoarchitectonic counterparts shown by the Zill's architectonic probabilistic maps with the 4A and 4P, with the 4P, which is the higher excitability component burning down in the sulcus, in the post-central sulci. This is the pictures for the hand. This is the pictures for the face area, even deeper inside of the sulci. These two components are characterized by different properties. The anterior one, lower excitability one, you have no recruitment at rest. When the patient is performing a task, you have dysfunctional interferences. In the posterior, instead, you have a motor recruitment at rest, and when the patient is performing a task, you have a tetanic interference. They are connected in different ways. The anterior component is connected with all the premotor cortices, the posterior mainly with the S1. The other important features of the primary motor cortex is the fact that when you stimulate one site, you induce there, of course, a D wave, but you have a series of I waves coming up in all over along the primary motor cortex. So this is the same that you can get with the CCP. When you have CCP, when you stimulate, for example, in the face area and you record it in the hand and in the leg area, you are going to see two peaks, one quite early and the second quite late. And this stands, in fact, with a complex horizontal connectivity of the primary motor cortex, one inside of the motor cortex and the other behind, connecting the different regions. You have also intersection inside, just below the sulci, that's this pli de passage present in different sites and corresponding neurophysiologically to intereffector area in which you can in fact induce motor responses, for example, in the hand subdivision of the hand, of the face, of the leg. similar to what has been really recently shown by advanced precision functional imaging mapping. The concept that you have to bring home is in fact that you have two systems inside of the primary motor cortex, an anterior polysynaptic, a posterior monosynaptic. And you can in fact identify these two components using qualitative and quantitative parameters. And by doing this, you are going to see that, for example, in patients with tumors like this one, you can dissect these two components, segregated them anteriorly and posteriorly in at least 50% of cases by using the train of two technique. But in 50%, you are going to see that the two components are still there, but are dispersed, intermingled. To use this is quite important because in some, at least in 50% of cases, it's very difficult to find a region, a cortical region, in which you can have a very low that is completely negative, or you are inducing motor responses at a higher current, with a higher current intensity. So region of lower excitability that you can use to enter inside and to approach the lesion. By switching in other way, in other words, just identifying and focusing on the high excitability component, you can redesign the map. And the message is that you can resect the lower excitability fibers and components and keep the higher excitability one. Just to give you an example, you are up subcortical level, the standard technique with the train of 5, you reach a response at 2 milliamp, you switch to train of 2, you see that you have a response with 8 milliamp, so you are far away from the fast conducting fibers, you are in the presence of the low excitability fibers that you can resect, and going down till you have train of 2 with 3 and 4 milliamp. What is the effect of that? Functionally, you have no deficit in terms of motor strength. You have impairment in the motor programming shown by the ARAT system that lasts a couple of days, mostly 1 week, and then in 1 or 2 weeks, the patient completely recovered. This is associated with an increase in extent of resection, both in gliomas and, as I show you, also in metastasis. Take some example of this. Of course, you may also end up in a situation in which, for example, after radiosurgery or radiotherapy, excitability of the fibers at the cortical and subcortical level is on the motor neurons, subcortical level is very low. And then you have to increase the current intensity by increasing the number of pulses and the pulse width to regain the ability to perform efficient mapping. Then we move to non-primary motor circuits. These are the cases that I am going to refer to. The functional networks involved in this region mainly phonoarticulation, prehension, movement, initiation. Of course, the same networks are also involved in attention, social interaction, and language. Just focus on the motor cognition part. First component, ventral premotor. We all know the ventral premotor is part of the articulatory network. This is the original work by Penfield, with a VPM that, when stimulated by low frequency technique, induce anarthria. Indeed, you can induce anarthria using low frequency technique, but also high frequency technique with a trend of 5, interstimular interval of 2, 1 or 3 hertz, and this is the reference in terms of current intensity. But if you are in a condition in which the patient cannot be waken up, how you can distinguish, how you can work in the ventral premotor? Well, you can use the high frequency technique, and then you are going to see that if you are using this, you can elicit from the ventral premotor motor responses of the face, of the hand, of the arm. And these motor responses are indeed characterized by a lower excitability. So you need a higher current intensity, 2, 3, 4 milliamp more than the primary motor cortex, and are giving to motor responses characterized by a longer latency. The typical pictures that you have is similar to the mosaic that you have in the anterior component of the primary motor cortex. Functionally, in fact, the ventral premotor is just a continuation of the anterior component of the primary motor cortex. What is the message of this? Is the fact that inside you can distinguish N1 and VPM fibers using the same protocol Treno5 and Treno2, and by doing this, even inside of the sleep setting, you can focus on the high excitability component and remove the lower excitability one. This allows to reset the tumor and to maintain function integrity. The second part is motor cognition, which is the action, the ability to interact with object, to learn how to interact. So the ability to shape, grasp, and rotate an object. This is the reason why we develop these tools that can be used in the theater. And you see that it's quite important to add to behavioral change also ENG interferences, because you see that and the rest is underpinned by different type of EEG partner, in fact. And you see in that region, you can have different pattern of EMG activity and interference that can be grouped into components. An anterior one located in the mesial region, in which the FST and the U fibers are mostly involved in the signaling between the SMA and the primary motor cortex to the basal ganglia, involved in motor output implementation, and another one in the lateral component going from the parietal to the frontal lobe, involved in sensory motor integration. This is the typical pictures that you can have during surgery. You are resecting, the patient is performing the hand manipulation task, you are stimulating down in the deep, and you have interference in the movement. You see that in this case, low frequency, the Payfield technique is the technique, the stimulation technique used. But you may end up in patients with a long history of seizure, medically refractory epilepsy, redo after chemotherapy or radiotherapy, in which low frequency is not working. You can have the same type of response by using high frequency technique with changing increase in the repetition rate from 1 Hertz to 3 Hertz. So you can regain again efficient mapping. The same technique can be also used to identify sites and circuits involved in motor awareness. Motor awareness is the fact that the patient, when he's performing a task or a movement, is aware to perform this. And the maintenance of these circuits inside of the primary motor cortex is crucial to maintain this action ability. What is the message of maintaining these premotor cortices and networks that are connecting the premotor areas toward N1? Is the fact that when you're maintaining this, you dramatically decrease the risk of inducing postoperative apraxia that is going down to almost 2-3% in most of the cases. And the need of a rehabilitation is almost completely abolished. The last part on the SMA. SMA is involved in movement initiation. The mapping strategy that we are using is to have, again, the patient awake for a short time. The mapping strategy, awake phase, to locate the lateral component, which is in fact involved in action and motor programming, then a sleep phase for the SMA proper. This is the connectivity that is involved in that area. You see that you have cortical fugal tracts from the SMA, fibers connecting SMA to the spinal cord, and you have the frontostriatal tract connecting the SMA and the PMD with the basal ganglia. You have also U fibers connecting SMA to PMD and SMA to N1. In fact, you have two components, lateral components from the SMA and particularly the PMD going down into the basal ganglia and back to the primary motor cortex that are involved in motor programming. You see that the same type of interference that you get in the SMA area, movement arrest or interferences, dysfunctional movement when the patient is performing then manipulation task, is in fact involved and induced when you stimulate the anterior component of the primary motor cortex. So are the same fibers. And then you have fibers that from the SMA and the PMD are going down to the basal ganglia, to the striatum. In fact, it's part of the loops, basal ganglia, thalamo, cortical loops. Anything new, well known for the functional organization of the basal ganglia. Then you have the motor response that you can induce when you work inside of the supplementary motor area, inside of the SMA proper. You induce motor responses involving upper limb and lower limb and involving proximal and axial muscles. This is the huge difference with the monkeys. More complex somatotopic organization and subcortical level contralateral motor responses, ipsilateral and bilateral, again intermingled. What is the message? The message is, if you remove these fibers, you have a high chance to induce a transient syndrome, the supplementary motor syndrome. But from a surgical point of view, your target is not the SMA responses, is the responses coming from N1 fibers. And you can remove SMA and keep and to reach N1 responses, and you know that you are safe if the MEP monitoring, so the MEP responses from the primary motor cortex induced by a cortical strip located over the primary motor cortex are in fact maintained. This raises the point that mapping should be always coupled with monitoring. MEP monitoring is a nice technique, can be done with a transcranial electrode or by DCS, so putting a cortical strip over the cortex with a reference electrode in FC. The advantage is the transcranial are giving responses from the initial part of surgery till the end. you have bilateral responses, failed in posterior approach, because in this case you have some air entering inside of the skull, and you have the risk that the current is not able to travel anymore inside of the brain to elicit a motor response. DCS is always working, but give you just information during resection. So when the cortical strip is placed over the brain and only on the contralateral side. This is the nice pictures of this technique. They are going up and down and quite informative when you are peeling a tumor from a vessels. But in some cases, you can end up, particularly in insular tumor, at the end of the surgery when you are closing, or at the end of the surgery and you are recording. You see that they are going away in 20 seconds, in few seconds. So this is telling you that something is going on. You can increase the blood pressure, you can irrigate, but it's something that in 1 or 2 cases over 300 motor brain mapping cases each year can happen. The final message is use basic and advanced tools and adapt these to the clinical context to extend the benefit of surgery to the largest number of patients as possible. Thank you very much. Open to questions.
Hello, sir. Can you hear me? Thank you, sir. Thank you very, very much for this amazing talk, and so for elaborating all the points very, very well. I believe we have got some questions for you as well. It was I think, a very informative and insightful talk, and I do believe that people must have questions. So there is some questions like, the functional reorganization that may lead to misleading of negative mapping results. So how do you see that?
Well, the concept of negative mapping is due to the fact that you are using a mapping tool that is not able to show, in fact, the real functional organization. I was able to show the limit and advantage of the different technique. If you are using the pain field technique, for example, you have a biphasic shots every 20 milliseconds, so you need a lot of charge, a lot of time and charge to elicit a motor response. Therefore, you get a motor response where you are over the fibers and over the motor neurons. And if the motor neurons has altered excitability, you may end up in the chance not to be able to induce any motor response because you are under threshold. On the other way, with the high frequency technique, you can play with the pulses, with the pulse width, and you can play with the charge. So you have more chance to induce a motor response in different clinical condition. Then, of course, depends on the questions that you want to achieve, in fact, and to answer. If you want to do standard mapping, 305 is more than enough. But if you want to address more specific and detailed questions on the functional organization, and therefore you want to dissect the different components of the motor system, you can do that by adding to qualitative parameters quantitative one. But this needs, of course, to have some experience and to have in the theater neurophysiologist or a technician able to read this type of information online, and a surgeon able to interpret this type of data online. But it's not so difficult.
Exactly. So thank you very much, sir, because there are a couple of things that people really wish to know, like the atypical activation patterns that are suspected to have been induced by tumors, and like the cross cerebrocerebellar activation that does take place and does have some effect on mapping and etc. So this is something that people usually really ask, and they really need to look at. So that's why it was a question, like reorganizations and all these things that are of great and a great interest. Sir, we do have a couple of questions also. Can I take it if you say, if you like? The first question is by Dr. Balaji. He's asking if we are using the TC-MAP alone during resection, sudden drop in MAP is noted. Then we are taking preventive measures like you mentioned, increasing blood pressure and irrigation. Also hold surgeries for 5 to 10 minutes. The TCS-MAP gets improved, but in post-op the patient had weakness. So what is your preventive measures and techniques used to make more precise mapping?
This is a very difficult question, I have to say, because of course this is surgical strategy, is a surgical strategy that you can in fact develop with experience and time. And I was able to show you the advantage to have MEP monitoring, but also the drawback. The drawback is in fact that when you have, well, the MEP monitoring is very nice when you are working close to a vessels and you know that you are close to a vessels and that you can, for example, asking to the neurophysiologist that the maneuver that you are doing are safe. If they are safe, the MEP are not really changing too much. The trick are the following. First, the technician or the neurophysiologist should work with a very constant MEP monitoring. So the MEP should be quite nice in terms of amplitude and polyphasic. When you are in a condition like this one, with 1 Hertz as a repetition rate, you can in fact depict every changes in amplitude and changes in latency. When you have a change in amplitude and a change in latency, this means that you are getting close to induce some vascular problem to the cortical part of the primary motor cortex. And therefore, these are very informative because can tell to the surgeon that he has to stop or she has to stop and then to work in another place or in a different manner. In this case, perfect, the system is working. But the drawback and the limitation of the technique is when you are far away or you are completely perform your surgery, you are closing the typical case of insular case, and you have some spasm from the deep perforators, and you are going to see that the MEPs are going down and completely disappearing in a few seconds. So there is no relationship with any direct surgical maneuver, but is due to the fact that you address and you enter in that region. Are informative that something happened. You can revert a little bit the condition by increasing the blood pressure, irrigation, and so on. This can revert the situation in at least 40-50% of the cases. But when you have a complete MEP loss and also some change in the SCCP, this means that a deep infarct of the internal capsule occurred.
Thank you very much, sir. Sir, there's another question over here by Dr. Paul Kunkem. He's asking, could you comment on the proposed model of primary motor strip with scan regions interposed between effector regions for foot, hand, and face, which is a Nature 2022 paper, and if there are mapping paradigms that can help identify these scan regions?
I have to say that thanks to the work in nature, and thanks also to the dissection that his group has done in Toronto, we were able to go back to what we have seen in the theater in the last 8 years, when we have been using the Treno 5 and Treno 2 technique. And we saw by this technique that when you were approaching the posterior part of the primary motor cortex, so the deep of the sulci, so where the fast conducting, the neuron component of the primary motor cortex, you can have this region where you induce at the lowest motor threshold motor responses from different effector. This was a finding. We still don't know what they are doing. We are investigating with the CCP and subcortical CCP, the different type of connection of this area. But at the moment, we don't know what they are doing.
Thank you very much, sir. There is another question. This is by Dr. Ahmed Fawad Mirzad from Afghanistan. He's saying, you salam and greetings, sir. This is an excellent lecture. The use of electronic devices, especially bipolar coagulation during operation, make artifacts. How do you prevent it?
Generally, 2 points. Generally, you have to use as much as less coagulation during this type of surgery, just when is really needed. The second point is that when you are using coagulation, this may interference with the recording. This is a problem of the IOM machine that you have in use. Most of the IOM machine that are used in Europe has internal software that are able to cancel this type of interferences. So even when you are using the bipolar, you can see and you can record MEP from the cortex or to perform mapping in the same way. But it is a technical stuff of the software that are used. I don't want to go into the commercial name, but there are many European IOM machines that have software able to cancel this type of interference.
That's brilliant, sir. Thank you very much, sir. Sir, we do have a couple of questions again. Your lecture was so much insightful. I believe that it raised a lot of questions. So, sir, there is another question from Dr. Gia Drost. He is asking, do you think that recording with surface EMG electrodes enable the difference of the different components of the motor system?
I have some line problem. I cannot hear you very well.
Okay, so it's okay. Sir, let's move on to, I think, the final question. Do you perform, this is Dr. Baron Sandoville. He's asking, do you perform motor multitasking mapping, or do you divide each task during the resection with the detailed information the train of two stimulation gives to you? Thank you, Professor, for your comprehensive and outstanding lecture.
Okay. This was important because it means that I was not really clear. First, when you want to use the Treno 5 and Treno 2 technique, this technique is a technique that you have to use in patient under general anesthesia. Why you have to use this under general anesthesia? Because under general anesthesia, the level of excitability of the primary motor cortex and fibers is stable. So you have to ask to your anesthesiologist to have a stable anesthesia. And you have to ask to your technician or neurophysiologist in the theater to check with the EEG and ECG that the level of anesthesia is not too deep. So you have to have an active EEG and active ECG and a stable level of anesthesia. When the level of anesthesia is stable, you can, in fact, measure quantitative parameters that you can induce with the stimulation technique. And you can measure MEP amplitude, you can measure the latency, you can measure excitability. So with the Treno 5 and Treno 2 technique, the patient is asleep. With, on the other hand, when you need to look at action, so to motor cognition, so the interaction between the primary motor cortexes and networks with the primary motor cortex, the patient should perform a task. CCP now can overcome a little bit this in the sleep setting, but the data are too primitive yet. So I cannot say that CCP can overcome this yet. But the standard is to have the patient awake. Generally, we are waking up the patients for a shortened time, 10 or 15 minutes only, and we are asking the patient to perform multiple tasking at the same time. This is done, in fact, because when you are performing different tasks, several tasks at the same time, 2, 3, 4 tasks at the same time. So you're asking the patient to perform a complex language task along with the hand manipulation task, for example. You are raising the level because when we are performing something, we are performing a task during the normal day living. We are in fact asking different networks to interact each other. And therefore, the best way to see this level of interaction is to have the patient performing several tasks. So in the theater, you have the neurophysiologist, you have the neuropsychologist asking the patient to perform, for example, the hand manipulation task, selective attention task, language task, complex language task. And at the same time, you can elicit responses from different networks.
So thank you very, very much, sir. Thank you very much for your time. You have already delivered a wonderful and very detailed lecture. And furthermore, you have elaborated almost every point that has been asked so far. So thank you so, so much. It means a lot to us. And it was an honor to welcome you today for our talk. This talk is recorded, sir. So I think that everyone will be able to get a benefit even after, after the webinar will be over. So thank you so much for your time. And I really wish to invite you again for one of our webinars in future. Thank you so much, sir.
It was a great pleasure and honor for me to be part of this.
So pleasure and honor is all ours. Professor Kostas had to go actually, on his behalf and on the behalf of the AANS and our Joint Center for Tumors, I myself is are really grateful to you for this amazing talk. So thank you very, very much, sir. And I really hope to welcome you again soon. And I think it is time to wrap up the session. But my colleague, Mr. Tim Edwards, really wish to share some guidance on how to claim CMEs, because as you know, this activity is CME accredited. So I'm just handing it over to Tim Edwards. Tim, the floor is yours now to please share how to claim the CMEs. And again, so thank you very much for your talks today, sir. It was an honor. Thank you.
Thank you so much.
Thank you.
Thank you, everyone, for joining us. The instructions for claiming CME are on the screen. I will be emailing everyone, so everyone who has been registered will receive an email directly from me letting you know that you have been registered in our learning management system. And then I will also include the instructions in that email. If anybody has any questions about claiming CME, feel free to reach out directly to myself or to education@aans.org. I'll leave these instructions up on the screen for a few minutes and give everybody a chance to see them before we close the webinar. Thank you.
Thank you so much, Tim Everett. Thank you very, very much. And I hope the recordings will be up on our YouTube channel so that everyone can actually go through it, and anyone who has actually missed can also see it. It's a very good privilege that all the videos are available. Like Professor Ghost has very rightly said, that our video library is getting bigger and bigger and very versatile. So you just need to go and just access our playlist and see everything that we have so far organized and every talk that has done. So I hope that you know that there are several talks in line from our section. So please don't forget to subscribe to our social media platforms, especially our Facebook. I think Facebook and we are also on LinkedIn, Twitter, and Instagram. Twitter, which is now called as the X. So I'm putting it in the question and answer section. This is our our YouTube address, from where you can access our playlist, our channel, and also I'm sharing our Facebook address, and follow us on Instagram, X, and LinkedIn for further, for future programs. We have got several programs in line, including a talk by Professor Gustas himself on June 9, and he will be delivering a very important talk on intraoperative fluorescence-guided surgery and photodynamic therapy for glioblastomas, a new combined approach. It's a very important talk, and also we will be having another talk on 2nd June. It is by the Spinal Oncology Subcommittee, and later on 6th June, there's a talk by Brian Choi. I hope many of you know he will be talking about cell therapy for brain tumors. So we have got several talks in line for the next month. So hope to see you all soon, and time for me to go, and bye-bye everyone. See you all later.